My name is Parsha Doris. I'm the neurologist here at Mission Hospital. I'm the head of the epilepsy monitoring unit and the chief of neurology as well. We are here today in the epilepsy monitoring unit to discuss a little bit more kind of the patients that are good candidates and qualify for being admitted to the epilepsy unit. One of the advantages of having a patient admitted to the epilepsy monitoring unit is the improved spatial resolution we have in the EEG. We have additional leads that we place on the patient in the frontal area that helps us get a better coverage of the brain, because the brain does have so many nooks and crannies, so to speak, and there is so many places that the electrographic seizures can hide in. And so we have more spatial resolution with these EEG montages. And the longer the patient is on an EEG, the more likely you are to be confident, based on the duration that they're hooked up, that you have captured what it is that you're looking for. So this particular patient was someone who was admitted to the EMU for reduction of medications in hopes of improving his side effect burden from the medications that he's on. And as you see, the seizure started, it generalized, and it continued on even after the cessation of the clinical activity. The patient still continued to have seizures on the right side, which continued on for over a minute despite the patient stopping his clinical seizure. So it does provide quite a bit of detail and clarity as far as what is being affected, how it's being affected, and gives us a lot of line of sight as far as what we can do to make adjustments to medications as necessary. As far as the type of patients that would qualify with respect to admission to the epilepsy unit, there are some criteria. Not everyone can be admitted that has a recent diagnosis of epilepsy. We typically reserve the admissions for patients who have new onset episodes of loss of awareness or neurologic changes that we don't really know what they are. Maybe they fainted, maybe they have seizures, we're not quite sure. Tremors that we're not really clear about the reason for. Patients who have a diagnosis of epilepsy and are having a hard time getting control over those seizures. So they have two seizure drugs that are fully maximized and they're still having breakthrough seizures. And then lastly, patients who have seizures, who are on medication and are looking to come off in a fairly safe and controlled environment of one or more of their medications. So making adjustments to their doses. Those are really the three kind of main categories and criteria that we look for when we look to admit somebody to the epilepsy unit. Once the patient is admitted to the hospital in the epilepsy unit and they're in the bed, that's kind of when the magic starts. Our technicians, who are highly skilled and highly qualified, they come in and they hook them up to the continuous EEG monitoring. So they have all the electrodes placed on their head, and it's put on in a fairly safe and secure way, and they're wrapped up so that it doesn't move around too much. And once they're hooked up, I'm watching them continuously. Someone is watching the EEG at all times to make sure that if there is anything that's remotely abnormal, even if the patient's not aware of it, that we have eyes on it and that we're trending it and making sure that it's not anything to be too worried about. And so that we can capture the seizure as quickly as possible and intervene as quickly as necessary once they do have a seizure or one of their targeted events. Let's walk through some of the common things that you will see in the epilepsy monitoring unit. So this would be the breakout box, which is what the electrodes will be connected to. So each of these is an electrode that will go on the scalp. The technicians will put on some gel or some adhesive glue, put this on, and make sure that it's placed firmly before wrapping the patient's head up to make sure that it doesn't move from its position. And it's tied to this little button here that looks like an eject button, but when a patient feels something unusual happening, they have an aura, they feel something strange, they feel like their heart is racing, or when they feel the seizure is starting or coming on, they push this button. And sometimes even staff or family who's at bedside will push it for them if they go into a seizure. What this does is it essentially creates a cascade of events. It turns the lights on, it shuts off the TV, it notes on the EEG when it was pushed so that whoever's reading it, which will be me, can look at that exact spot and see what's going on at that time to see if we can correlate clinically what's going on electrographically with the patient's EEG. One of the next pieces that I think is important to look at is the photic stimulator. So what this does is it's essentially a bright flashing light that we can change its frequency to. So we can increase it from 4 hertz to 8 hertz to 11 hertz, all the way up to however many hertz we feel needed, to provide a visual stimulus for the brain to see if it will help trigger a seizure, because there are some seizure types that are provoked by flashing lights. Our job once they get here and they're hooked up and in the bed is to essentially watch them and do everything that we can in our power to capture the event, because that's going to give us the highest yield as far as what the event in question is. So we reduce their medications gradually over a period of time, depending on the case, depending on the dose and the drug type. We sleep deprive them while they're here, we flash lights in them, we make them hyperventilate, we do everything that we can that stereotypically provokes someone to have a seizure, all for the purposes of having a seizure in a controlled environment. Once we've captured a seizure, it really depends on what we're doing. So it depends on why the patient was admitted. If they were admitted to characterize these events and we capture one and it certainly is a seizure, well, we kind of have our answer. We know why they're here. We know that these are seizures, and we can move forward accordingly with their medication and adjustments and changes and so on and so forth. If we are here to make changes to medications, we know that once we reduce certain medications to a point that they are going to have a seizure, so we are able to kind of find the parameters and the limits of what we can and can't do with respect to their medications. And once we have enough seizures in a patient who is a pre-surgical candidate, analyze the EEG, look at where they're coming from, and place them on a list for pre-surgical candidacy evaluation. And once that decision is made, we proceed forward with the next step, which would be either evaluation for surgical resection or a phase 2 monitoring, which would be invasive EEG electrode placement. The Epilepsy Care Consortium, looking at it from the inside, is really, I think, in my opinion, the future of how this care is going to be managed. We have over 8 facilities that are affiliated. We have 2 children's hospitals affiliated and multiple facilities in LA and OC that are involved in this care. We have neuroradiologists affiliated with USC that are looking at all of these cases individually. We have multiple neuropsychologists looking at it. We have a comprehensive approach to care for these patients, and it is one that I don't think is replicated anywhere else in the state, let alone elsewhere. Our affiliation with USC has been explicitly with the intention of providing high-level academic care close to home, so patients don't have to travel but still get the high quality that they were looking for. Center of Excellences are not just handed out. You have to kind of qualify for them, and you have to make sure you do your due diligence to make sure that you prove to the Epilepsy Centers of Excellence that you are qualified and that you are doing everything you can to reach that level of care and that high quality. And one of those things is making sure that you see enough patients a year to ensure that your volume is appropriate and that you are providing all the resources necessary. And so USC has been really helpful in making sure that we are on that path. And very shortly, once both of our beds are fully occupied, we should be reaching that milestone in the near future. I graduated from USC in 2018 from a program that specializes in epilepsy. Since then, I have been here the entire time. When we opened our doors in October of 2019, we opened it right before the pandemic started. So that put a bit of a wrench into things and limited our numbers. But since reopening in March, we've had over a dozen admissions at this site in and of itself. I graduated my residency from Virginia Commonwealth University, which was a very epilepsy-heavy center. So I had several thousand hours of EEG, several hundred cases of EMU admissions in the 3 or 4 years that I was there. And once I got to USC, I did over 100 cases in that 1 year that I was there, ranging from as simple as one-day admissions all the way up to full surgical resections, in-depth monitoring with grids and depths placed. So my level of comfort with these particular challenging cases is fairly strong.